by UConn Health. I see we have President Merrick with us, Dr. Agwanobi, Mr. Gagan, Dr. Leong, and Mr. Lapowski, who I don't think we've met. Nice to see you. You are presenting on your financial position, I guess. I'll turn it over to you.
Thank you, Secretary Beckham. Before we start, I would like to thank everybody for the opportunity to be here and present. And we are very grateful to state and everybody who supports UConn and UConn Health for your support of our students, for support of our faculty and staff. And we are going to have the fruitful discussion where we are going to talk about our vision, our revenues, our expenses, and we are very open to have a dialogue and actionable feedback. What are the things that we have to consider to sunset, and what are the things that we have to expand in order to build financial sustainability at UConn Health. And we are in great hands. Our CEO and President, Andy Agwanobi, we call him Andy 2.0. He's going to take over. Thank you.
We can't see the people.
Thank you very much. Thank you, President Merrick. And so I'm Dr. Andy Agwanobi, as everyone has said, the CEO of UConn Health. And I, too, would like to thank the co-chairs, so Senator Austin, Representative Walker, of course, Secretary Beckham, and all of the Higher Education Financial Sustainability Advisory Board. And I'd also like to thank, because this board is really important, I know it's a lot of work, I'd like to thank Undersecretary Charlene Casamento, who's been very helpful, and also Susan Keene as well for all the work that she does. And that's a heartfelt thank you, because I've been excited about coming to this committee and presenting today, because I believe that the work of this committee will help us as we look for ways to be even better stewards of the amazing trust and support that the people of Connecticut have put into UConn Health. I'm joined today, as been noted, by the deans of the School of Medicine and the School of Dental Medicine, as well as our Chief Financial Officer, Jeff Gagan, who's here to answer questions as they come up. Again, it's a privilege to be with you all today, and I welcome your guidance and questions. I think the last sort of introductory comment I'll say is that our goals are aligned. The goals of UConn Health and the goals of this committee are aligned. You know, I returned to UConn Health 4 months ago, and I returned to UConn Health for 2 reasons. The first was that I believe deeply in the value that UConn Health brings to the citizens of Connecticut. But I also believe that the next phase, and this is where the 2.0 comes in, the next phase of UConn Health is one that, based on the great foundation we've built and the amazing growth that we have so far and the demand for our services, I think that we can reduce, and this is me, one person's opinion, as I evaluate things, I believe we can reduce reliance on the state, even as we efficiently expand services to more residents. Today, I'm not going to be discussing thoughts about plans related to the Kane Brothers report, explorations in that regards, because it's still ongoing. But I can say that I've been public about the fact that I believe with the right partnership strategies, the right growth strategies, that we can, over time, we can reduce our reliance on state support for the clinical enterprise, John Dempsey and the clinics. You'll see later in the presentation that support that we internally allocate is around 60 million, 59 to 60 million, which is a pretty sizable 30% of the 200 million that we receive in the state block grant. And I think we can do that while preserving our important public mission and academic mission as well. So today, again, I won't be discussing that plan, but I will be discussing other areas of opportunity. And it will also include bringing in a consulting firm at some point, and we're looking at that to look at partner with us to look at our expenses and look at opportunities to help us look at opportunities as we go forward. So we'll go forward and we'll talk about, do 15 to 20 minutes introductory presentation. We'll be focusing on, as you can see, the financial highlights, some of the constraints that we're facing, and areas of opportunities that we're either exploring already or we're actually implementing. Rest assured, in this introductory presentation, I'll be spending very little time on UConn Health's value and benefit to the state. I will touch on it, but mainly today it's about looking at opportunities for improvement that we're already exploring and looking at some of the constraints and getting your feedback and thoughts on that. So we can go to the first slide. So the School of Dental Medicine and the School of Medicine, they provide sort of immense value to UConn Health and to the state of Connecticut. The best indication in my mind of value is not just me sitting here and touting that and saying they're great, but it's really looking at the admissions demand or the application volume, the people that are applying for spots in these schools. And you can see here that 80%, so you could see that that School of Medicine had 5,360 applicants for 112 spots. And the School of Dental Medicine had 1,600 applicants for 52 spots. And you can also see that 80% of the School of Medicine students are Connecticut residents, and 60% of the School of Medicine students are Connecticut residents. And down to the right-hand corner of this slide, you can see that the admissions demand has been growing steadily year after year. One of the other measures of value to the state of Connecticut is, well, how many physicians and how many dentists continue to practice in Connecticut after they graduate. This number of 37% is actually a little bit higher than it's a correct number, but it also includes residents. So those who are specializing, they've graduated from medical school, they're specializing in pediatrics or orthopedics or whatever it might be. So I think a more conservative number is to use about 25%. So I would say 1 in 4 physicians that graduate from UConn Health, from our School of Medicine, practice in Connecticut. And about 65% of the dentists practicing in Connecticut are from our School of Dental Medicine. So again, I think this is just an indication, objective indication that there's a lot of demand for our schools, and that, you know, Connecticut has done a great thing in terms of helping support these educational institutions. Now, the schools have tried to respond to this demand by increasing class size, and you can see that they've increased class size by about approximately 10% for each of them. We can go to the next slide. So these are just some financial highlights for the schools. So what you see here, if you look at along the bottom, state support, and by the way, I'm going to maybe redefine that, not as so much as state support, but as the amount of funds that UConn Health receives from the state. There are other ways that the state supports UConn Health. The total there along the bottom is about $200 million, which is the block grants, how much we receive from the state. And this just shows you a breakdown of that amount. By the way, $200 million is 13% of the total revenues that UConn Health generates. We generate about $1.6 billion in revenues, and that's about 13%. Now, of that, $112.9 million, as you can see there, is internally allocated to the schools for teaching. Research is separate. Now, if you look at the second bullet point, it's difficult to compare us with other universities because it's not necessarily apples to apples. Some of them might include dental students, some might not, some have larger number of students, some have less. But I thought just directionally to just get a sense that of what other schools receive from the state. And you can see, I think it's understandable that we're somewhere in the mix. You know, there are other, SUNY Downstate receives less than we receive, but there are others that receive more. And I think it's just a directional guide to say we're in the ballpark, but I think a lot more work has to be done, probably even visiting those universities to make sure the numbers are apples to apples, but we want it to be transparent. The other thing I'd mention is that the schools also generate funds themselves, obviously. So tuition and fees, $34 million, as well as about $15 million in net income from specialty training. So that is when they're training these orthopedics, cardiology, specialties, et cetera, that actually has a positive return to the schools of about 15 million, which is also an opportunity to expand that as well. So if we go to the next slide. So just talk a little bit about constraints. We've spoken about strengths here and some of the challenges, which challenges, by the way, are also opportunities. One of the constraints is that we have a limited opportunity for further increase in tuition. Remember the 34 million in tuition and fees that I talked about? That is actually higher than the median of Northeast schools for a School of Medicine. In terms of the School of Dental Medicine, their fees are about the 50th percentile of dental schools in the state. Now, I say it's a constraint. It's not an unsurmountable constraint. We're actually going to increase the tuition by about 4.5% for the schools. So we do increase them, but it's not an open-ended where you can sort of just go as far as you want to go. Otherwise, that will impact the ability of people in the state to enroll. A bigger challenge is that the nature of physician education, in other words, you graduate from medical school, and then everybody who graduates specializes in something, even if it's primary care. So the nature of that is when physicians graduate from school, they then apply across the whole country for specialty programs. Now, we do pretty well in terms of being able to keep 30% of those graduates in the state for their specialization. But there's opportunity because 70% of them leave to specialize elsewhere. Some of them come back, but some don't come back. So there's opportunity there to increase that 30%. Another challenge is class size, and this is just a logistical, practical challenge of class size being limited by space, faculty to student ratios, and availability of clinical placements. Now, all of these they're not hard constraints where we can't do something in those areas, but it's just something that the medical school has to take into account as they look at their alternatives. So we'll go to slide 4. So let's talk a little bit about opportunities for improvement, and we'll get to the hospital and the clinics in a moment, but we're still on the schools and the School of Dental Medicine and the School of Medicine. So one is improving physician retention in the state. I mean, I think one of the most frequent questions that I get asked is, well, how can we keep more physicians from the School of Medicine in the state? And to be honest, this is something we have to do better at, and we're putting our heads together to think about. One of the things that the state has already done that we're very thankful for is the student loan repayment program, which is actually being administered by UConn Health. And we think that's going to help in terms of retaining physicians in the state, particularly in underserved areas. I've talked already about increasing tuition and fees. So I think last year was a 3.5% increase, and we're going to do more this year, like a 4.5%. And so leaning into that, even though we have to be careful not to price ourselves too high. Growing the residency programs. As I mentioned, that 15 million, which is positive from having specialty programs, growing them is great. And also growing them helps with the workforce as well, because they're training, but they're also seeing patients, and that's good as well. Rankings is one that I know the dean of the School of Medicine is very focused on. School of Medicine is ranked 31st by US News and World Report in research and primary care. And I know there's opportunity there, and the school is focused on that. School of Dental Medicine, I think, is already in the top 3 nationally. So not too much improvement there, but both are solid schools. And you can take a degree from UConn Health, from the School of Medicine, School of Dental Medicine, and you can go anywhere in the country, and they do. People go to Harvard and they come back to us. They go to Yale, they go to the Ivy Leagues. It's regarded as a solid educational program, and that is a testament to the support of the state over many, many years. We can always further increase federal grants. There's been a significant increase since 2017, as you can see, about 54%. But there's always room for improvement to increase federal grants. And we actually, myself and the Dean of the School of Medicine, are launching a research strategic plan to advance, more clinical trials, more translational research, and more commercialization of research. The only other thing I'll mention here in opportunities is primary care. Graduating primary care is a national problem, but having a school that graduates primary care physicians is an opportunity for us to figure out ways to get more students to choose primary care and then to stay in the state after they choose primary care. So a lot of opportunities there, and obviously we're going to be open to more discussion on this. We can go to next slide. So we're switching gears here, and we're going to talk about what we call the clinical enterprise, which is John Dempsey Hospital and our physician clinics. This slide is actually from the Kane Brothers report. And the reason I use this slide is because, again, it's easy for organizations to toot their own horns. It's better if they're tooted by customers, as I talked about, students in the case of the schools, or third parties like a consulting firm such as Kane Brothers. If you look at all of the metrics except the CMS star ratings, and in the CMS star ratings, you can see, and this is the stars in the sort of middle column, you can see that we and Yale New Haven Health System are rated at a 3-star. I'll come back to that in a moment. But apart from those, if you look at the metrics across the board, UConn Health has really become over time a healthcare powerhouse in the state of Connecticut. You look at safety, 7 safety A-grade safety ratings in a row. Patient experience is top of the pack. Revenue growth has just been unbelievable over the last 4 or 5 years. So 15.3% CAGR. Admissions, we're full. I walked through the emergency department yesterday, and we had over 5, unfortunately, elderly women boarding in their beds in the corridors, waiting to get transport out. So there's a real huge demand for our services. And as people know, we've applied for a certificate of need because the hospital is full. And again, this is third parties, patients, customers saying, we like the services you're providing. We believe that, Connecticut is providing us with services that we can be proud of and that we can bring our families to. And so a lot of good work there. In terms of the CMS star ratings of a 3, again, this is not about us sitting down and saying, oh, we're great. This is an area that we absolutely have to work on. And I've talked to our chief medical officer and our hospital staff and everything. The CMS stars relate specifically to Medicare Advantage and pay for performance plans. It doesn't affect our fee for service, which is the bulk of the work we do in terms of our patients, but it affects our value-based plans, which are smaller in terms of the plans that we have. And right now, it doesn't affect us financially in any way in those plans, but if we fell below 3, it could have an impact. So we want to be sure that we get it up to 4 or 5. And these are based on surveys that they perform about sort of recommendations and provider work, et cetera. So we're working on those. We go, and then of course, I love to look at the narrative to the right, and then we'll get off the sort of the value. But this was from the consultants. UConn Health's patient care enterprise has market-leading patient experience and quality of care metrics. It has also shown impressive growth for the last few years. And it says taking market share from local private sector competitors. I would say that we've never deliberately taken market share. We just focus on providing excellent care to the people that come to us, and we let the rest take care of itself. But that's from that report. We'll go to the next slide.
Dr. Ray, it's okay with me if you aggressively take market share from somebody else.
Yeah, thank you. We like patients to come to us. Yeah, let me put it that way. Financial. So let's just talk about some of the financial highlights. So we're off sort of the strands. So the amount of revenues, just for ground setting here, the amount of revenues we receive from the state declined by over 50%. From fiscal 23 to 24. But I want to be clear with everybody that the state still has those costs. The state, that was a shift of state costs to the state. So the state still has those costs. And that's why I don't call this state support. State support is greater than we have here, but these are the total funds that we receive from the state. Sorry. Yes. And I also want to say that in terms of as those costs were shifted, the legacy costs were shifted to the state, it's been very helpful to us from a research perspective, particularly, because we're able to submit research grants without, you know, a 70% or a 65% fringe rate on them. Still a little bit higher than private sector, but definitely an impact. And I want to thank everyone from the state, legislators, leaders, for that. It's you know, it's very helpful, and you got it done. And so I appreciate it. Now, if we look at our non-state revenues, you know, this is the bottom blue line, which says total revenues excluding state support. So I thought I'd take those out and just look at our non-state revenues. Again, the state revenues are 200 million out of 1.6 billion. So when we look at our non-state revenues, those increased over those 2 years by 9.5%. In fact, if you go back further, if you go from fiscal 2019 all the way to the future, fiscal year 26, in terms of what we projected, it's been an unbelievable increase in patient revenues. It's actually a 94% increase in patient revenues. At the same time, if you look at our expenses, and what I did here is I removed the fringe reduction, because again, if we can't count the fringe reduction, which went over to the state side as us reducing expenses. But if you take out that fringe reduction over those fiscal year 23 to 24, our expenses increased by about 6%, which is obviously less than 9.5%. So I think, you know, there's a good sort of directional momentum in getting our revenues up and getting our expenses to track behind our revenues. I don't have fiscal year 25 on this slide. We will see it in a moment, but fiscal year 25 will be a break-even budget. So that's the year we're in now, with, of course, when we include the 59 million or 60 million in internal allocation of state support. You might ask, well, why do we need an internal allocation of about 59 million or 60 million? Why do we have that right now? And it's a combination of factors, but it includes Medicaid reimbursement for specialty services. It includes mission services, behavioral health, some of the losses and things that we have there. It includes, I would say, if you compare with other organizations, that we still have a fringe rate, a little bit of a more fringe rate than our other private not-for-profits. And we don't need to be there, but this is just kind of as we think about why is that in there. And then we have, and this is our challenge, we have managed care rates that are below where they need to be. So we need to figure out, you know, how to get our managed care rates higher. And then, of course, there's just the cost structure that's inherent to a teaching and research institution where your physicians are not just seeing patients, they're also teaching and doing research. So if we go to the constraints for the clinical enterprise, constraints, next slide. So constraints or challenges include that although we are projected to break even with state support, as I just said, in fiscal year 25, in fiscal year 26, we can only do so if that support is maintained. And, you know, our plan for reducing reliance on state support, the plan that I mentioned earlier that I'm not going to be talking about today, will be stepwise over the next few years. So we anticipate that fiscal year 26, because we're almost there, we'll need that support to be maintained, despite the fact that there'll be a cessation of ARPA funds. So that's obviously a challenge. Also, none of the submitted numbers, so this is another challenge, none of the submitted numbers include the CBIs as per the directions. We haven't included our collective bargaining increases in these numbers, so that will be something else. So again, I'm not saying this here to request anything. It's really just to say these are challenges that we, and when I say we, I mean collectively, we and the state, the leadership, everybody will have to kind of come together and sort of figure out what the best path forward is.
I'm going to forget this if I don't ask it now. You have included here this the collective bargaining increases. Did you include the increases in tuition that you anticipate? Because you said you were going up to a 4% tuition, and I'm looking at your tuition fees from 34.2 to 35.1. Is that the, you received just slightly less than one?
Yeah.
In tuition increase when you
Yeah.
go up that much?
Good question. Do you want to talk about the tuition increase?
So I'll just say two things. It does include the tuition increase, and there is also fees and a lot of other tuition lines that go into it. But the other aspect, it does not include any salary increases. So that's the
I got the
difference.
salary increases over here.
Yeah,
That's why, but your tuition increase is what this year? Three and a
so
half?
it's this year was 3, correct.
And you're going up to 4.5?
So that is the proposal. I don't know if we've actually got approval for that. I think that's still in the proposals.
Well, that's what I'm trying to figure out is by only going up one is, or less than one, that's a percentage and a half, 1.5%. Doesn't seem right.
Right. Do you want to talk to that?
Yeah, thank you, Senator. For school medicine, this year, 3.5%.
Right.
And we do it 2 year at a time. So this is the first year of the 3.5%, and next year will be about the same. And the plan is for the next
Next
2
year.
years after this 2 year cycle, we're going to go up to 4.5%,
So
which
this-
might explain the smaller increase that you see.
Well,
right.
I think what the senator is saying is that when you do the math here, you're saying it's one point something percent, correct?
I'm saying I don't see a 1.5% increase over this year.
Okay.
And your 2 years are fiscal 24 and 25 at 3.5%. Your next 2 years are at 4.5%. And so that doesn't look like a total dollar amount. I just would need to see
Yeah.
the data or the detail there to see if
Right.
that's equivalent to an increase of that magnitude, because it doesn't see, I don't see that.
Yes, absolutely. We will get,
Yeah,
Thank
we'll
you.
break out the
Right.
detail. Again, this is School of Medicine, but it's also the School of Dental Medicine, the graduate schools. So I think it's a little over 2 or 2.5% after we net it, but we'll get you the detail by school of what each one is in fiscal 26.
Thank you.
yeah. And thank you for pointing out the CBI increases. These are we're just showing what the impact would be to UConn Health with the different CBI increases. Obviously, we're not.
And your CBI increases are 1, 2, 3, 4, 4.5. But there is no union contract that goes so it doesn't say which year. So
Yes, no. So this is hypothetical. This is just saying,
Okay,
if
I
there
think
was a
that's-
1% increase, it would be an 8.3 million impact. If there was a 2% increase,
we're in another contract negotiation right now, right? We should be very shortly. Must be in a state employee contract negotiations, Jeff.
Discussions have been had.
Right.
Okay.
thank you. Thank
So this is, if there is a 1%
Yes, just
increase,
hypothetical. Thank you. for
If
calling it out.
because I was not reading it that way.
Yeah,
I
I'm
was-
sorry. I should have explained it properly.
No,
I
you did.
apologize. Right.
I didn't get that.
So,
So,
okay, so we can go to the next slide. This slide refers to our unrestricted but committed. We choose that carefully, the wording carefully. These are unrestricted but committed fund balances. And I guess the challenge we have here is that the fund balances, most of which are committed, fall well short of our deferred maintenance needs. And I will say a couple of things. One is we prioritize, and that's what we're going to have to continue to do. We have if you take into account inflation on top of a consulting study that was done on sort of our deferred maintenance needs, it's been updated to 400 million. But the reality is, we can and we do prioritize, and we will continue to prioritize over time. But it's something that we have to keep our eyes on as we go forward.
so I'm going to go back I'm going to go to this question too. I'm sorry, Mr. Secretary, may I ask a question, please?
Yeah.
So you're including in here fund balances on research and academics. But those have finite terms, right? Your research and academics have finite programs that you're working on. And to compare that to the deferred maintenance and capital doesn't make any sense to me. So that the committed funds based on your research, which we, by taking on the fringe benefit costs, have allowed you to receive more research dollars, but that, are you including those research dollars in a standard that says that when we lose these dollars, we don't have enough to cover deferred maintenance? I don't see the connection between research and academics in relative to grants in particular. So I'm concerned that benefit costs have allowed you to don't make any sense.
Right. I think we've lumped them all together, but you want to say anything about that, Jeff?
So I think the actual table on the left-hand side there is pointing out, if you go to the bottom on the estimate, we have 250 to 234 million, depending on the year.
Yep.
That is the amount of cash that we have set aside at the end of the year.
Yep.
The table above is just to show where or who those cash balances sit. So the majority or the highlighted portion there in that deferred maintenance and capital, those are projects that we have funded and we basically have approved in our balance, but we haven't spent the cash yet. So that's there. And then above that 70 million area, that's just showing those are balances either in the school or in research or in institutional support.
So I don't see the comparison between deferred maintenance and capital into committed fund balances. I don't see that. I'm trying to understand, why would we keep, why would we put in deferred maintenance and capital? So for this last budget cycle, relative to capital at UConn Health, the legislature approved dollars associated with capital improvements. We increased the amount of money that we would put in. I'm surprised that we would not take deferred maintenance and capital expenditures and have it in its own tab. That would be reflective of the money that we have approved in bonded dollars for UConn and UConn Health. Unless I'm missing something here, I don't see the connection between research and academics and deferred maintenance.
Yeah, answer that question, please. So when you think of research dollars, when we receive the research dollars, we have the packet, what can it cover? So any break-in equipment has to come outside of the research dollar. Any adoption to facility that you receive the research has to come out of research dollars. So the capital investment for the research product, and many of those projects, you are also aware, Department of Energy requires 20% of the match. Department of Transportation requires 50% of match. So when we look that category, what Jeff said, it is a budgeted that when those research dollars come, you have to show how you invest and how you match the federal dollars.
So I get that, that there's a match that would be incorporated into, you need a widget to do a specific grant. So whatever that widget costs, you need, but you calculate that into your application for a grant, right?
No, you cannot calculate. You have to put money aside. So when the research dollars comes, and I will give example to Department of Energy. So each quarter you have to report how did you spend the research dollars and how did you spend the money that was matching money from institution.
Right.
So
I get that, but when you are applying for a grant, as a grant application is being made, that grant application, which ultimately is approved by your board, right? Or somebody approves the person applying for the grant application, And you know, as an institution, what you have to do to match that grant, but that is not deferred maintenance and capital, in my opinion. That is a incorrect title. So deferred maintenance should be in the regular budget of UConn Health, not in, I think that all education from pre-K through higher ed thinks that deferred maintenance should be paid for by somebody, some amorphous person up here. I'm trying to say that deferred maintenance is part of your operational budget, and capital, the dollars that are matching the grant should, in my opinion, should say research and academics, what you receive in private grants, and a line item that says down here, what we are required to put in as a match to get that grant. So you're making a decision on getting a grant, right? You're making an application for a grant. Somebody has to say, in this grant, we have to put some of our dollars aside for that. That's not a capital investment that we take on. That's a capital investment that UConn takes on, or UConn Health takes on. Or I think this is wrong. This gives a wrong impression, in my opinion.
I think that's fair. I think we can break it out, right?
So, yeah, I think we'll have to have more discussion. Just a point of a clarification, this is all operating money. This is not bond funds, either UConn 2000 or GO. So this is just operational. And this is in the budget every year. But for instance, if we were, doing deferred maintenance of a $10 million project and it was funded in 24, but it was not spent, that's why it's in this balance. These are the amount of funds that are still left over that weren't spent, but they are committed to projects.
I understand that. I still think that we're not showing the cost of that grant application. So every grant that I would get for a town. So I would say, so the state gets 80% funding from the federal government for highway projects. 20% has to come from the state to allow us to get that 80% on that project. That is not deferred maintenance and capital. That is the cost for the grant application that we have. So I'm saying the grant application is X. And in order for us to apply for this grant, so when you are applying for a grant, there has to be somebody that's saying, we're going to get X and we think that this is a really great program to work on, but this is not only going to cost us the grant application, it's going to cost us dollars that we're going to ask for from the state, from the feds, from some private donor. And we want to know that we know that these dollars, if it's 50%, are related to this grant. We want to know and I just don't see it fits into, in my mind, the deferred maintenance and capital.
So,
I
Senator, we really appreciate the thoughts on this, and we'll go back and split it out and maybe come back to you to make sure we get it right. So we appreciate it.
And the pledged debt surface is bonded dollars, right?
No, those are the debt service that we have internally. They're not related to the bonds.
So debt related to what?
The majority for UConn Health is the outpatient pavilion, which is the physician office building on campus in Farmington.
And you're paying for it because you have a bond, an
We have an
internal bond.
outstanding mortgage with that.
Yes. So that is another thing that I think that, is it only that one thing?
No, there's other minor outstanding leases, and we do have one other mortgage on a building on campus also.
So can you get us that data too, please?
Sure.
Thank you.
Absolutely.
Thank you. And then I think I'm coming to the end of the presentation. If we go to the next slide. So these are more opportunities for improvement. As I said when I did the opening sort of comments, that given the growth of our revenues and patient volume, we've already reduced the amount of internally allocated state funds. I'm talking about internally allocated state funds that the clinical enterprise, that's John Dempsey Hospital and the clinics, needs. As you can see, going down each year. And we're down to 59 million that we internally allocate. And that is the number that I believe we can work on. And figure out over the next few years how to get that down, actually even eliminate that amount. Again, we're just exploring plans for that, but that I think is what we should be focusing on. The green line, by the way, is the patient revenues that are increasing, whereas the dark blue bars show the clinics and the hospital's internal allocation that's decreasing. And I think, with the right partnership strategies and the right growth strategies, we can really work on that 59 million. Another opportunity that we believe strongly in is increasing philanthropy. In fiscal year 24, we raised 8.4 million in philanthropy, and most of that, 7 million of that, was for the School of Medicine, and 1 million was for the hospital. An independent hospital, a sort of a hospital like we have, separately licensed. Over time, we think we can get a multiple of that 1 million. In fact, Yukon Health as a whole should be able to raise tens of millions of dollars each year. And so we're partnering with the foundation in strategic planning, and I just met with them this morning. Go to the next slide. So these are some, this slide relates to some efficiency projects that we're engaged in. And there are two categories of projects. I won't go through each of them. You can read them yourselves. But one is sort of artificial intelligence, and the other is energy efficiency. On the energy efficiency side, you could see the first one. I'll just talk about the first one. We have a fuel cell installation project that will save about $2 to $3 million annually with Bloom Energy. So that's a big one that we're doing. And then when we talk about artificial intelligence, one of the ones I'm very fond of is artificial intelligence scribes. And that's basically when physicians enter rooms, instead of having a person that walks with them and takes notes, as we often do, particularly for our very, very busy physicians, you can actually have, there's solutions out there like Ambient and others that a physician can walk into the room and they just talk. And it's recorded, AI sorts through it using natural language processing. It goes into the electronic medical record directly, and it's a big saver of time, efficiency, and money, of course. And by the way, documentation for physicians is one of the biggest dissatisfiers because it's just a burden on them as they're trying to see patients. There are many others. You can read some of the others there, but these are just some of the efficiency projects that we're engaged in. And then the last slide, this is my last slide, and this is really other cost savings and revenue enhancements. Again, not including our response to the Kane Brothers report. These are things that we're doing regardless of that. And there are two work streams that I'm showing here. One is what we call our annual financial improvement plan. And it's the box, the table you see here. The target we have is for fiscal year 25 is 15 million. Now, this is not incremental. This is actually baked into the budget. So if we didn't have this financial improvement plan, the budget would be short by 15 million, but we're going to make sure that we hit that target. And you can see some of the initiatives there. One of them I wanted to give an example of is telesitters. These are it's almost like a little robot that sits in the room with patients instead of having a one-to-one human sitter there. Now, obviously, it has to be appropriate for that, but this will save us about half of our costs from having one-to-one individuals sitting with patients. Again, we wouldn't use this for behavioral health. We wouldn't use it for very, very sick patients, but it's something that we can use and monitor centrally for our patients. Also, of course, hiring contract agency staff, reducing the number of agency staff that we have to use, looking at our staffing, slowing down hiring and things like that. We have 2 vacancy review committees, one for faculty, one for other staff, to make sure we're not just automatically filling vacancies, but at the same time, we're balancing the patient care needs. And then finally, the last bullet point at the bottom of this page is, we haven't talked about this extensively within Yukon Health, but I have been talking about it, saying that I do believe we need to bring in a firm to partner with us looking at efficiencies as part of our strategic plan that we just kicked off. So we're crafting an RFP for that, and we'll be sending that out. So that's just my introductory comments, and we're happy to take any questions, guidance, thoughts that you might have today as we enter the discussion. And
Thank you, Dr. A. Great presentation. Representative Walker has joined us online and has a question.
Thank you. Thank you, Mr. Secretary, and thank you, UConn, for your presentation. I'm going to leave my camera off because I'm not, I'm involuntarily stuck in my house right now. So I hope to join you in the next meetings. My question is, first of all, could you send us maybe a breakdown of your cost of doing business, so that maybe some of the things that I think some of the things that my colleague was looking for would be important for us to see some of those things. But I want to jump and change to something else. I want to know, is the cost for medical school at UConn, is that comparable to other medical schools? Are we competitive? Do we still keep the prices down so that we don't lose students, especially from Connecticut? And in your interest or your increases in tuition, have you looked at how many students have potentially dropped off in the state of Connecticut, at least because of that increase?
Yeah, we'll have our dean answer that. Thank you, Representative.
Thank you, Representative Walker. This is Bruce Lian, Dean of the School of Medicine. Thank you for your question. We did call out some numbers from other public medical schools that receive state funding. University of Maryland, UNC Chapel Hill, University of Buffalo, Rutgers, Robert Wood Johnson, upstate and downstate. I think Dr. Andy had mentioned those numbers, and we are actually a little less than those schools from the medical school standpoint, and UMass received less than we do, so we are in the mix, but I think we are not excessively getting state funding to educate our students. We do have concern about state residents who want to come to our medical school and not being able to afford it. So just as a benchmark, the average indebtedness of all U.S. medical students is about $250,000 when they finish. 250,000. They have just beginning to get into the real workforce to earn a living, to raise family, and perhaps own a house, but they're already indebted by, on the average, $250,000, and some of them are as much as $400,000. And we're very conscious about not imposing that kind of level of indebtedness, especially on the Connecticut residents who want to come to the medical school. Nevertheless, our tuition is still a little bit more than the median of all public schools and all private and public schools in the Northeast. And while we do want to increase the tuition more to try to cover some of this gap, as indicated, they're not as high as Buffalo, Rutgers, UNC Chapel Hill, or Maryland, because we wanted to be conscious of the cost. We also wanted to be concerned with the level of indebtedness, especially of Connecticut residents who tend to stay after they finish.
Exactly.
Their parents are here and their families are here.
That's my concern. Thank you for that. But my concern is the fact that I don't know about you, but a lot of people have contacted me because, and I've gone through this, we are running low in like primary care doctors and a lot of other specific fields. And because of that, it's becoming more difficult to actually get the services that we're looking for because of the lack of physicians. So every time we make increases, that's going to affect, I think, the number of people that will actually try and go to medical school. So I think we need to do more to encourage people to participate in this area. So I thank you for your presentation. I do have some other questions, but I will probably have to send them in because I'd like to be able to have a little bit more explanation on some of the dollars that you identified in your presentation, Dr. A. Thank you.
Thank you, Representative Walker.
Mhm,
Please
thank-
send us any queries, questions you have.
Thanks.
Thank you, Representative Walker. Can I ask you about the faculty-student ratio at the medical and dental schools? You alluded to accreditation standards that presumably prescribe some kind of range of acceptable ratios. Where are we on that spectrum? Is there room to do more in terms of number of students per professor?
Go ahead. Bruce.
Thank you, Secretary Beckham, for that excellent question. We have a good faculty to student ratio, which I think explains the fact that our students sought after graduating from medical school. Dr. Andy mentioned that. Just to give you some statistics, this last year, 86% of our graduates matched to one of their top 3 residency programs, and 56% got matched to their first choice, which is as good as it comes, even compared to the Ivy League medical schools. And so we encourage a good faculty to student ratio. Our faculty to student ratio is probably in the upper echelon compared to other schools.
Where is it in terms of you said there were accreditation standards that were applicable to that ratio. You say we're at the top end of that, or?
Yes. So where the accreditation standard comes in is the fact that you got to have faculty who could mentor medical students for their scholarly activity, which is a required accreditation standard. And I would just say that majority of our employed faculty at the medical school shouldered that responsibility to mentor the students for research and scholarly pursuit. And that's the accreditation standard.
I see. So it's not a number.
No.
It's not an actual numeric ratio.
Correct.
Okay, I got it.
Steve, did you want to say something?
Yes, Senator Beckham. With regard to schools of dental medicine, there's no fixed number, but it will vary depending on the setting, whether it's a classroom setting, didactics, preclinical, clinical. We average approximately 8 students or 8 learners per faculty member, which is at about the 50th percentile of all U.S. dental schools.
Okay.
I do want to share that when we increase the class size from the starting point of 40 to where we are at 52, we did so with no measurable increase in the number of faculty. So we kept the faculty numbers relatively stable. We've also made some investments in some technologies that allow students to do some of their preclinical work independent of an in-person faculty. So their work is captured digitally, and faculty then can review and provide feedback asynchronously, so that we're not intentionally pushing the faculty numbers to any appreciable amount.
I think you showed me some of that technology when I toured the school a year or so ago. Yep. Okay. Senator Austin, who is a senator.
I told him he lost money when you promoted him. So I have a couple questions relative to the Medicaid revenue, and on page 8 of your presentation, it talks about the revenue coming in, and it says net patient revenue. And I'm curious, is that net patient revenue include Medicaid revenue coming in? Do you
Yes,
have
it does.
I'm sorry.
Yes, it does.
Does it, can you break that down so we can see the difference between the Medicaid revenue and other private pay? So we
Absolutely.
could break that apart. If we, so over the last couple of years, we have not increased a lot of the rates in Medicaid, but we have increased some. And we are looking at different possibilities of increasing Medicaid rates, talked about all the time in the press. I'm not guaranteeing anything to anybody, to be very clear.
Good answer.
Not guaranteeing anything to anybody, to be very clear. But if you could give us an idea on which Medicaid rates mostly impact UConn Health, so that we understand what are the rates that most negatively impact you based on what you're receiving from them and what would have the greatest impact to Yukon Health, it would be very helpful. That's really one of my
Yeah.
biggest areas here. I know you, and the percentage of patients that you see that are Medicaid
Right.
eligible would be also helpful. I don't know if, I think you have a pretty high percentage.
Yeah, we have I think it's about 25% in general, but when you go into the specialties like orthopedics and things like that, we have pretty high percentages comparatively. But we'll look into that. And also, I think on the hospital side is where we have most of the sort of Medicaid shortfalls. So we can split
Right.
that out and send it to you.
It would be helpful for us to see what that is, to map out what Medicaid, where Medicaid patients are, what part of the services they're getting, and what rates haven't met the current cost of that particular service.
Will do.
Thank you.
While we're on the topic of Medicaid, you talked about getting the CMS rating from 3 to 4. What would it take to do that? What are the shortfalls that you're seeing in the?
Yeah, it's a great question. It just takes a focus on those specific categories. There's something like 46 different sort of categories, timeliness of care, different things that we need to look at. So it's really just a focused effort. We're very good on quality in general. Our quality is very high, but you have to check specific boxes for CMS. So we just have to go back, and I've already tasked our chief medical officer with looking at that. So
Is that something you could share with us?
yes,
The boxes to
absolutely.
be ticked?
Absolutely.
Okay, great. Other questions? I've got a couple more. Let's see. So I get the message about keeping you whole, whatever that means. We obviously have had a series of discussions about what that means. The ARPA has gone away. That was the extra money that we were able to give, and that's not with us anymore. Of course, our regular state agencies had to live up to the lapses that the General Assembly in their wisdom provided in our Appropriations Act. We've had to assign holdbacks to our line agencies, but no holdbacks were applied to your block grant. So doing what we can to help you there. I know you have reserves. We talked a little bit about your reserves, and you've obligated some of that or plan to obligate that for deferred maintenance. But I think that number has gone up quite a bit in the last several years in terms of what's available. It's gone up 4 or 5 times by my math since 2019 timeframe. So a lot of extra, right? Not 1920, 2019 and 2020 has gone up quite a bit. It was about 17 million in total for deferred maintenance available in 19. Now you're showing 152 million. So that's a pretty big increase of what's available to you. With regard to the deferred maintenance, we did extend Yukon 2000, and quite a bit of capital projects have been done under that, and quite a bit of bond funds have been provided over the years. So that's also a new innovation in the last year that's available for your maintenance needs. So suggesting a possible alternative use for some of those reserves might be this buffer you think you need to be held whole. Just a suggestion I'll put out there. Can we get some detail on the projects though that you mean to obligate this deferred maintenance to? That'd be good.
Yeah,
We could get a list of
absolutely.
those projects.
Yep.
I'll just finish on a couple of two things that I see in this presentation that give me great hope. Is one, the emphasis on philanthropy. I know the governor was concerned about that when we extended Yukon 2000, wanted to give some incentive to do that, certain amount of philanthropy every year going forward to not to match, but at least to get some extra assistance. So I want to encourage you to continue to think in
Yeah.
those terms. As well as it's my page 6, the commercialization of the research.
Right.
That's something we talked about when I was out there a year or so ago. I heard a lot of great stories about drugs and devices, all happening on your campus or in partnership with others. I know that there's an issue around who's the inventor, who's the creator, who gets the benefit of that. But it seems to me if they're using your space, your property, your time, whatever, we ought to be participating in some of that that commercialization.
I couldn't agree more. It was really interesting when I was coming back, you know, myself and President Merrick had a meeting of the minds that this is a huge opportunity. We're actually having a kicking off strategic planning tomorrow with some of the leaders of research. And what's interesting is what we're focusing on. We're always going to grow basic research and do that, but we think there's outsized opportunity in the area of clinical trials, translational, and commercialization of research. And so we're really going to lean into that. But thank you. I think it's a great point.
It's interesting.
I want to go back to talking about AI a little bit.
Mhm.
And you talked about a scribe that that a doctor could walk into
Yeah.
a room and speak, and that would be
Mhm.
translated in whatever fashion. Is there any concern that having that AI mechanism decreases the intimate relationship between the doctor and the patient, or the understanding of what is happening between the doctor and the patient? There are some nuances in language and just in general attitude that happens, I think, and I'm
Yeah,
just
I think-
curious about that.
Yeah, I mean, I think you're right to sort of raise sort of cautions and say, you know, whenever we're talking about a new technology like AI, you have to be ready to implement it and take into account some of the downsides that could be there. I think institutions across the country in particular are looking at use cases, and one of the use cases is scribes, and partly because it's such a huge problem for the physicians to be documenting, and there's not enough scribes or enough money to have medical students or clerks, you know, doing that. But we're doing it as a pilot. So we're launching a pilot in a couple of months. We're going to be launching a pilot, a very narrow pilot, to understand what the impacts are,
Right.
both in terms of downside and upside, before we go forward with it.
So this is something that's already being implemented
As a pilot,
as a pilot.
As
but
a
it's
pilot.
being implemented as a pilot. and
Yes.
You are looking at
right?
a way to deal with this. So if I'm somebody that doesn't really understand my medical condition, may
Right.
not use the correct terminology, and the doctor is
Yeah.
talking with that person, and this is being scribed as people are speaking. It's
Yes.
not being looked at afterwards. Is there
Oh, no,
somebody?
no, it is. It is. We would have it looked at afterwards by physicians. Now, I guess during the pilot period, we want to make sure that it's accurate and that it's
Right.
reflecting what the physician thinks. And if that's not happening, then we'd have to fine tune it, or the model would have to be retrained. But certainly these are concerns that we're going to take into account as we launch the pilot.
I'm not saying I'm opposed to this. I really want to understand it more,
Mhm.
because I am concerned as we head into the AI
Mhm.
field of things, and whether or not that should be a policy decision that's made
I see.
by the General Assembly,
Mhm.
that we
Interesting.
agree with the policy
Mhm.
of AI. And I know the doctor wants to say something. I agree that the doctor should not have to describe everything that's going down. In particular, we've all waited in a doctor's office saying, what are they doing? And they're actually, key punching in whatever they're key punching in. I always want to read what they're saying about me afterwards, but I'm a little worried there too. But you also have, and before the AI in radiology.
Yes.
How would that work?
Yeah.
Um,
So that has actually been implemented already in Yukon
Okay.
Health, and it works extremely well. And what it does is, what they're using it for now mainly is so let's say each day a radiologist has 300 films to read,
Right,
or a brain bleed or something like
Right.
that. The AI will read it first sometimes in milliseconds. It will read all of the films and say, you should focus on number 1 and number 2 and number 3 because there's a small bleed in each of those.
right.
So we're using it as a safety measure, but we're still reading them. Our physicians are still reading those films. And we use them after as well, just as a quality check as well. And it works extremely well. We've launched 3 or 4 modules for
So-
radiology.
So, there is a check and balance on AI, that AI is not operating independently from the real minds of the people that we're counting on to do the work.
Yeah, absolutely. 100%.
I know that.
Yes.
Thank you. I want to try to answer your questions about whether the AI scribe is going to impact negatively the doctor-patient relationship. And I would, as a practicing physician, I can tell you right now, I struggle when I'm in the exam room because I'm going to try to talk to the patient, maintain eye contact, and type. Okay, and so it takes away my ability to really engage and talk with the patient. And what this would do is I'm not going to need to type anymore. I can focus on talking to the patient.
Okay.
And when I leave the room, that AI scribe is going to type it, already transcribe it for me, which I will proofread and make sure the terminology is correct, and then click sign. So I think I anticipate that this is actually going to be helpful in enhancing that doctor-patient engagement.
So I'm going to take this initiative to a different realm. So one of the things that a company like UPS did was they decided to track the number of minutes that it takes to deliver a package. And they figured out that if they were tracking it, how many steps you would do and how, you drove up, they never took into account if the person had a big dog or they had a pothole in the middle of their yard or whatever. So they said, you can deliver 35 packages in 2 hours and 22 minutes, 28 seconds. Do you think that taking that scenario and saying now you don't have to scribe anymore, you can now see an additional 10 patients.
Yes.
And so at the end of the day, you're not only going to have to proofread from the original 20 patients that you were seeing, you're now being required to see an additional 10 patients. So you're going to see 30 patients instead of the original 20. And because somebody else has decided, and
Right.
We have very big institutions that are handling our healthcare now. We have Harvard Healthcare, we have Yale, we have UConn. And those decisions made on the human capital of those systems is being decided by someone that is not necessarily a practicing physician. They're making decisions saying, oh yeah, we looked at it and the numbers show that we've saved them 24 minutes and 20 seconds. And we think that they can now see an additional number of patients. And at the end of the day, when you're going through everything, you have to keep in your mind the 30 patients that you saw, not just the 20 patients that you saw, which is already going to be hard to, in my opinion, to remember exactly what happened with each patient.
So Senator Austin, you're bringing up very valid points. These things can be misused. I'll say a couple of things. One, in UConn Health, and maybe it's because we're a smaller organization, we're very, very in tune with our frontline physicians. So for example, I personally, along with Jeff and others, we actually do empowerment meetings for all of our top specialties, where every month, and this is monthly, where we sit in a room with them, the people who are the leaders of those who are on the front lines, and we ask what are the issues that we can work with. So we feel now, other people could be in these shoes at different in future, so it doesn't negate what you're saying, but we feel very confident that we're really in touch with our faculty. But I think more broader than that is a part of our planning for UConn Health, in addition to things like AI and efficiencies, et cetera, is well-being for our employees, including our faculty. So this actually a strategic plan element where we need to work on what are the things we need to do to make our frontline faculty and our employees feel like they're cared for, feel like they're fulfilled, feel like they belong, and that someone cares. And part of that is when we implement something like AI, as I mentioned to you, it isn't just implementing it for cost savings, it's implementing it so that we reduce the what they call the administrative burden on our physicians and eventually on our nurses as well. And so that means not doing what you said. Now, it doesn't mean that if someone has a lot more free time, that we couldn't see more patients that need to be seen. but it can't be to the extent that it is impacting that, it's not relieving the physician of the workload that we're trying to relieve them of. So, but I think it's a very good point.
And so I think AI is fascinating, but I am extremely worried that we're taking out the human element
Yep.
in a lot of cases. And I'm not certain that, you know, I met with some 25 people that came from Haiti, Brazil, Peru, Ukraine. Some of them had degrees from their country that what they're trying to do is to learn English. They're English language learners, and they're trying to learn English so that they can take the tests to be able to practice here in this country. And we desperately need them to come to work in our medical fields. But are people going to understand all of the accents associated with the different languages that we have out there? I'm wondering if we have looked at what the United Nations does in order to interpret different languages in a way that would ensure a certain amount of fidelity when you have AI doing this. Your training school, you have a lot of people that are coming from other areas. We certainly want to have more Connecticut residents, but you have people coming from all over the world to come and learn from you, which I think is a very good thing. But when AI is transcribing, is there going to be fidelity in that understanding of their language?
Well, it's interesting. You're bringing up one of the problems that prevented AI from being used up till now, and that is how do you make sure that what it's transcribing, one, captures the right elements, and two, that it actually understands what people are saying, whether it's the provider's accent or the patient's accent or what they're talking about. And I think that's why I think the general feeling out there is that it's got to the point where it can handle that. But that's why we're being very careful. And, you know, we're implementing this as a small pilot initially. And just the way we are in UConn Health is we're going to make sure that we're comfortable with it. And we'll still be monitoring it. As you know, Dr. Liang said, we'll still have physicians, you know, looking at this and saying, does this really say what I said, or, you know, relate to what the discussion was? So all, honestly speaking, all very, very good cautions. It's not without trepidation that we go forward with a new technology, but I think if we do a pilot in that, first of all, we'll mitigate our risks.
I just want to add to the technology of this AI scribe. Actually, you have to first train the scribe your voice. So if you have an accent, I still have a little bit of an accent. I was born in Taiwan. I immigrated here 40 some years ago. And so I train my voice with this device so that I noticed that with time, they are very accurate now. I really have to go back and change. So you could train your voice.
But your patient, it's not trained to your patient's voice, and your patient may have an accent that you understand well, but the scribe may not. So there is not just the accent on the physician, there's the accent on the patient that you're seeing. And in particular, at a training institution that we have here, and with the number of Medicaid, the percentage of Medicaid patients that you have a number of people that are not necessarily primary English speaking people. I just have one last question, and that is relative to the reading of charts and x-rays. Does this in any way impact, because we have a very bad impression on not just in Connecticut, but in the United States, on minorities receiving the correct care. Is this something that if someone is reading a chart, if this AI is reading a chart, does this help to ensure that doesn't happen, or does this hurt that? Is there any bias in a AI mechanism that reads a chart and doesn't necessarily see it in the same way, depending on whether the gender or the racial makeup of the person. I am just curious about that, and that will be all I will ask.
You want to try that? Yeah.
I think that is a real issue when you rely on AI and machine learning to come to an interpretation of the data. What does this mean? The problem there is a lot of the clinical trials that enroll patients are skewed. They're not including enough minority population. So the conclusion that the machine learning would do is based on incomplete data set. So that, I think, is the issue. But I think for the scribe, it's just mechanically getting that right word. But you're right. I think training the provider voice is only half of that battle.
And I also think you're right when it comes to the chart, because a lot of interpretation and some of the social determinants of health might not be included in the right way. I think with films, it's different because it's films. It's like reading an X-ray. There's very little. There's a lot of objectivity in that. So, but yeah, these are all very big topics that we have to consider.
Thank you. Are there other questions from the board? See anyone online with their hand up? I just have one more ask, and you don't have to answer on the fly, but if you're aware of, in the course of the last year or two, we've discovered the IPEDS system, which is the system the federal government has for comparing universities in terms of things like the faculty-student ratio and your expenses per student and stuff like that, and tuition and reliance on the state. Are there academic sort of medical school or dental school benchmark organizations that show expenses per student or faculty student ratio? I'd be interested in just seeing that if there was anything like that, so that we could get some kind of a comparison, as well as the clinical side, in terms of the hospital, the relative value unit per clinician, that sort of thing. We'd like to see some kind of,
Yep.
you've got benchmarks where you
Get some
are
benchmarks.
nationally on both those,
Mhm.
in terms of both those institutions. That'd be great.
Yeah, we can provide that. Absolutely.
I'm aware of some of the work you're doing behind the scenes. You didn't talk about it today, and I understand why. We're not going to talk about it anytime soon, unless and until we get to a place where it might be something relevant to discuss publicly. But as I told you, when I heard about it and we talked about it, I'm very impressed with it. It's creative, it's thoughtful, it's innovative, and I'm hopeful that we can get to a better place soon in terms of the financial sustainability of your institution. So, but I know there's a lot of hard
Well,
work gone into it, and I appreciate
Yeah,
it.
well, I appreciate your leadership. You've got a lot of challenges, and you're leading a steady ship there. So thank you.
All right. If we don't have any other questions, we'll let you get on with your day. Thanks for coming. Good to see you, Madam President.
Thank you so much.
With that, we will, next item on our agenda is to, actually, do we have a quorum? Can we approve the minutes? No? Oh, well, we'll do it at the next meeting. How about that? We will announce the time and date of our next meeting, which looks like Halloween, October 31st, 1 o'clock in this room and via Zoom. We'll see you all here on Halloween. You don't have to dress up. It's all right. I have a motion to adjourn the board.
So moved.
Without objection, motion carries. We'll see you all soon.